overnight orthokeratology in myopia management and its control. Orthokeratology is a simple, safe, non-invasive, highly effective US FDA approved technique for management of myopia, but is much less known and even less practiced amongst ophthalmologists. To highlight the importance of orthokeratology in improving the quality of life in children, I'll present a few cases. My first case was a 16-year-old girl who was a marathon runner. Her unaided visual acuity was 6/60 in right eye and 3/60 in left eye. She had a myopic astigmatism. Spectacles were a major handicap for her, as it would affect her performance in the races, as she had to continuously wipe the glasses, whatever sweat was falling on the glasses. So I managed her with orthokeratology, and she went on to win a 50-kilometer run and an award of 50,000 rupees, and was also selected for the Asian Games. Another patient, 17-year-old boy, was a national level golfer. His vision was 6/36 unaided in both eyes, and he had a myopia of 2.75 diopters. His requirement was a clear natural vision without spectacles or contact lenses. On treatment with orthokeratology, he went on to win an award of 2 lakh rupees in a major tournament. A 19-year-old girl had come to me when I was in Jammu. She came for treatment of calazion and removal of glasses. Again, her vision was 6/36 in both eyes with a myopia of 2.75 diopters. I prescribed the lenses to her, and next I saw her in the movie No One Killed Jessica. Now, this 14-year-old boy was a complex case. He had a mixed astigmatism, and such cases don't respond so well to orthokeratology normally. So I was a little reluctant to prescribe him glasses, but he had come to me with a lot of hope, having visited all the centers in Delhi NCR. His main problem was he was interested in sports, and he would play football, basketball, badminton without glasses and would frequently get hurt. So on treatment with orthokeratology, he's improved to 6/9 both eyes, and his quality of life improved, and he has been under follow-up for last 8 years, and recently he has undergone contour LASIK. So orthokeratology is a very effective modality and is particularly useful in children and adolescents, as the option of LASIK is not there. It's the science of changing the curvature or shape of the cornea to change how light is focused on the macula. We all know that the refractive power of cornea is about 43 diopters, and being the first refractive interface, it harbors most of the eye's corrective power. So manipulation of cornea can help in treating myopia, and this is the basis of orthokeratology and various corneal refractive surgical procedures. Orthokeratology acts on the 50-micron thick epithelial layer, which is a continuously regenerating layer. The compression force required to induce change in the corneal epithelium is very minimal, and being the first refractive interface, it brings about a major change in power and hence is comparable to LASIK. High success rates have been achieved with reverse geometry lens designs, high oxygen transmission lenses, and overnight wear. This is the design of the orthokeratology lens. You can see that the base curve is flatter than the cornea and exerts a gentle compression on the corneal epithelium. The second curve is the reverse curve zone, which has the space between the lens and the cornea, which sucks in the tear film and creates a negative suction force and allows the intracellular fluid also to move. This brings about the thickening of the corneal epithelium under the reverse curve zone and thinning in the central optical zone. The next are the two alignment curves, which help in the centration of the lens on the cornea, and the last is the peripheral curve, which allows the tear film exchange. So this is the orthokeratology lens placed onto the cornea, and this is the ideal fit. You can see that each ring of fluorescence is concentric to each other. So when the lens is placed on the cornea, Initially, the corneal epithelium is of uniform shape, and over a period, it gets compressed in the center and thickens under the reverse curve zone. This corrects the myopia. So while the patient is asleep, as these are overnight wear lenses, the lens changes the surface of the cornea. On waking up, once the lens is removed, the myopia is neutralized and the patient can see clearly throughout the day. Over a period, the epithelium again swells up and comes back to normal, and it's time to place the lens again back onto the cornea. This animation will make it more clear as to how orthokeratology acts. You can see as the lens is placed on the cornea, it exerts a gentle compressive force onto the central corneal epithelium. Over a period, the epithelium gets compressed in the center and it gets thickened under the reverse curve zone. In the morning, once the lens is removed, the patient is able to see clearly as the myopia is neutralized. So the ideal candidate for orthokeratology is a juvenile to adult myope with -1 to -5, and almost it works in -6 diopters also. A normal spherical lens can neutralize up to 2 diopters of astigmatism, and toric orthokeratology lenses are available which can correct up to -4 diopters. And it's ideal for sports person, people working in dusty areas, and so on. This lens works like magic. Within 1 hour, most of the myopia is neutralized and most of the patients achieve a vision of 6/6, especially mild to moderate myopia patients. 70 to 80% of reduction takes place with the first night of wear lens only. Maximum effect is seen at 3 weeks, and after that the patient can titrate how long he should wear the lens. The effect usually lasts for 2 to 5 days, and the patient can wear once in a week or once in 3 to 4 days also. Low myopes get a better effect. So it's a safe, non-invasive, cost-effective, reversible technique suitable for children, and most importantly, it does not require any expensive infrastructure, and it has been shown to slow down the progression of myopia. So how does it help in slowing down the progression of myopia? I've already shown this slide earlier. This lens converts the peripheral hyperopic defocus into a myopic defocus. You can see that the thickening of the corneal epithelium takes place under the reverse curve zone. So while the patient is wearing the lens, the rays traveling through the reverse curve zone come to a focus in front of the retina, leading to a myopic defocus. And once the lens is removed, the thickened corneal epithelium, this ring of thickened corneal epithelium, creates a myopic defocus. As a result, this myopic defocus is sustained throughout 24 hours. And this sustained myopic defocus helps in controlling myopia progression. And this has been brought out in various studies. The first study was LORIC in 2005, which showed that it has a preventive control on myopia progression. But at that time, it could not say whether it was any predictable effect in individual cases. Then came a meta-analysis in 2015, which showed that orthokeratology is effective and acceptable for slowing myopia progression. And they suggested that an early intervention should be done to reduce the prevalence of high myopia. The ROMEO study in 2012 first documented that it slows down the axial elongation by 43% and reduced the fast progressors from 65 to 20% in subjects in the age group of 7 to 8 years. And it also suggested that it would be beneficial to commence ortho-K treatment in younger children. Another meta-analysis published in Current Eye Research compared orthokeratology with spectacle lenses and showed that it had a significant efficacy in controlling axial elongation. It showed that better effect was seen in Chinese children and those with initial high myopia. Recently, another study came for combination treatment with atropine and orthokeratology, and it has been shown that both orthokeratology and atropine have a synergistic effect, And if combined with 0.01% atropine, it can have effect similar to 0.05% atropine. In high myopia, orthokeratology doesn't completely reverse the myopia, it only causes a partial reduction. But even in such cases, the myopia control effect is there, and it was shown that in these partial reduction cases, axial elongation was reduced by 63%. Similarly, toric orthokeratology lenses have also been tried, and at 24 months, it has also shown that the progression was 52% slower as compared to the control group. And this correlated significantly with the initial age of the subjects. So orthokeratology not only reverses the myopia, but it also slows down the progression of myopia. It's the bridge towards effective myopia control. Thank you. Yeah, so the house is now open for questions. If you have any comments or questions, you could ask. We have 3 minutes left in the course. No, a well-fitting lens. You have to be sure when you have to do an orthokeratology trial, it's a 1-hour trial. Once you get the ideal fit, then you prescribe those lenses. An ideally fitting lens will not cause any problem. And these are high decay lenses, and these are approved for overnight wear. So it doesn't cause any damage to the cornea because oxygen transmission is good. Surprise, there's a company, Lucid Korea. It has placed a stall here in this exhibition itself, and we have the Indian distributors here.
How young the child should be so that you can prescribe orthokeratology?
I have a number of children of 7 to 8 years age group also, and I've realized that the patient really respond to it very well. You need to train them first, and you need to train the parents also, either mother, usually it's the mother who accompanies the child, and you have to be sure that they can handle the lenses. The hygiene is of utmost importance. That is the only thing you are scared of. So you have to first counsel the patient, make them practice in front of you. Once you are convinced that they can handle the lenses at home on their own, then only it should be prescribed.
Have you encountered any complications like corneal complication or dry eye, or do you prescribe any artificial tear in these cases?
When we do orthokeratology workup, we normally don't prescribe these lenses if the patient has dry eyes. And in any case, lubricants are given because they help in helping in placing the lens and removing the lens from the eye. So when we are placing the lens, we place a drop of tear substitutes onto the lens, and then we place the lens on the cornea so that it smoothly fits placed on the cornea. And in some cases, it happens that when the morning the lens is adherent to the cornea, it doesn't come out very easily. That's why these days 5-curve lenses. This was the problem with the 4-curve orthokeratology lenses. In 5-curve lenses, another alignment curve has been introduced to remove this problem of adherence. So in the morning, it's better to place 1 drop of artificial tears in the eye, ask the child to blink or the patient to blink 2-3 times, and then you remove the lens, then it becomes easier.
Thank you. This is a question for the panel. So I do mostly ROP cases, so they end up with myopia. So what is your suggestion about dealing with the childs in the future myopia?
Yeah, so whenever you're prescribing these interventions for progressive myopia, that is one thing you have to rule out. It should not be ROP, not should be syndromic myopia, should not be congenital high myopia, should not be prematurity. So these are things where you don't use any kind of intervention because that's a lenticular thing. You have in ROP, the myopia is lenticular because of the anterior segment arrest. So the axial elongation is not much. I mean, the maximum it will reach is about 20 to 23 millimeters, which is normally metropization. And the myopia usually it's axial myopia, it will usually start after 23 millimeters. So in ROP, not of much use. I mean, it's like having an initial high myopia because of because of the lens, and probably trying to stop that 22-23 millimeter elongation if you give atropine. That's not really required in these cases. So it's not an axial myopia, it's a lenticular myopia in ROP.
So traditional glass is the only way to out.
Yes.
way out.
Yes.
Thank you.
So I
Even
thank you all.
glaucoma is the same thing. We all have high myopia and glaucoma also, congenital glaucoma. There also I don't think it's recommended.